Namaskar, you all are welcome. We are going to continue our series for neurology for medical students. So today we are going to start cerebrovascular diseases and this we are going to cover. I can show you the lesson plan. You can see here we are going to cover cerebrovascular diseases, risk factors, causes, mechanism, pathophysiology in quite detail. We are going to talk about occlusive and stenotic cerebrovascular diseases as well. Transient ischemic attacks. Sorry, there was a spelling mistake. Yeah. So, and my throat is also a little dull. So I'm really sorry for that. Clinical syndromes we are going to see, that's very important. Large vessel occlusion basically, and we are going to see complete anatomy, and based on anatomy how you can actually understand where the symptoms will come, which all symptoms will come, and the symptoms are originating from which part of the brain. So we are going to see in correlation with the anatomy. Then we are going to see a very short note on the lacunar stroke as well, LACI. It was question in some of the examination asked by few of the students, they were saying. And then embolization, of course, and then we will be talking about the investigations, various methods of investigations, and what actually you see in case of stenotic and occlusive diseases. Then we are going to see the management of cerebral infarction, management of TIA and minor infarction, hypertension and CVA. We are going to see a a brief prospect, like how it is interrelated, and we are going to talk something like special about it. And then we are going to understand about cerebrovascular diseases unusual forms, I'm going to discuss later. Then we are going to talk about intracerebral hemorrhage as well, okay, how it affects, what all the management has to be done, and then obviously what all the symptoms, of course. Till that time you will be able to understand the how the symptoms are there, and then how it is it can come from various part of the brain and then can be understood. Then subarachnoid hemorrhage, this is also a very important question. And then cerebral aneurysms we are going to see in very kind of detail. Arteriovenous malformations also we are going to see. So we are going to continue this series in quite descriptive manner. And for a student of physiotherapy, we are going to have a separate discussion over how we are going to manage the patient of the stroke when it comes to the physiotherapy, okay, right from the inpatient to outpatient as well as to rehab center or at home. Well, but before that we are going to see these all medical part in quite detail. So let us start with the introduction part, okay. And vascular diseases are amongst the most frequent causes of admission to the hospital, especially in the Western countries, okay. And if you see the incidence alone in the UK, it varies regionally, right from 150 to 200 per 1 lakh, and it has a good prevalence of 600 per 1 lakh cases, of which 1/3 are severely disabled, okay. So this is how just a minute. Yes, I'll see that. Just 1 minute. Just 1 minute, please. I'll increase the font so that everybody can see that. This should be okay. Yeah. So cerebrovascular diseases, basically, as I said you, this is one of the very important causes of admission to the hospital, okay, and especially in the developed countries. So before getting into same, but stroke is what? Stroke is basically I would say the generic term, right? A generic term. It doesn't have any pathological meaning, it lacks pathological meaning, so we are not going to take this name a lot. Yes, in general term, we are going to say the stroke, but stroke, it doesn't have any pathological meaning. So, as long as we are studying this chapter, we'll be talking about cerebrovascular diseases in, this is the word we are going to discuss a lot. Yes, good question you asked. Good. So let us talk about the risk factors. Okay, what all? Just a minute. Just a minute. So what all risk factors? Anybody can? Can anybody say that? In fact, anybody can say me, no problem. Yes, wonderful. Hypertension. Then let us have a bullet pointing here, right? That will be very good to understand that. So hypertension is the major cause. Yes. And if you talk about hypertension, then as I said, it's a major factor in development of basically thrombotic type. Okay. Yeah, thrombotic and intracranial hemorrhage, thrombotic cerebral infarction and intracranial hemorrhage. But there is no critical blood pressure level for that. Yeah, somebody asked me like what is the blood pressure level that we should understand that. No, there is no critical blood pressure level. Okay, do one thing, student. Let me list first of all these risk factors, then we are going to discuss one after another. It will be very easy for you guys. Okay, fine. Then of course heart disease will not say cardiac disorders, cardiac diseases. Then of course diabetes. These all are predisposing factor. These all are the risk factors. Heredity. Of course, heredity. Race, human race. We are going to talk about it. Don't worry. Then of course hyperlipidemia. Okay, hyperlipidemia or habit of smoking. You can say the diet factor also. All the personal things, who all were present when I was taking the assessment class. Then obesity factor, right? Smoking, diet, obesity factor. Well, yeah, I wrote it together. Yes. Then anything else? Okay, I'll tell you. Hematocrit value. You know what it is, right? Oral contraceptive pills. Okay, oral contraceptives. So these all are the reason. Okay, it has been listed. Now now let us understand hypertension. Let me tell you, let me highlight it. Hypertension, no critical level. Okay, no critical level. Normally, no critical level. It can come to any of the hypertensive level. Okay. If you talk about the risk obviously it is proportional to the increasing level of blood pressure. Okay. A simple calculation, if I say you can remember 6% fall in I would say DBP, diastolic blood pressure, is associated with 40% fall in risk of just 1 minute, I'll increase that. 40% fall in risk of any kind of stroke, okay, or CVA. Well, understood? Yes. So there is no particularly critical level, so don't worry. It can always be associated with any kind of, higher the value, higher it will be. Okay. Well, cardiac diseases, especially what we say, cardiac failure. Okay, cardiac failure, or yes, wonderful, but let us say it as enlargement. What you said, it's one of the symptom of, symptom associated for a very long time, then it can cause, yes. And then arrhythmias, okay, all kind of irregularity at heart that can actually, just 1 minute, arrhythmias, yes. Now, okay. Arrhythmias, okay. If you see the systemic part, then rheumatic heart diseases also. Okay, so these all are the risk factor. It's not coming. Okay, rheumatic heart diseases. You all be knowing patent foramen oval, isn't it? So these all are has been seen with the increased risk of cerebrovascular diseases. Diabetes, well, you can say twofold risk increases with diabetes. Okay, yes. Now let us talk about heredity. I would say close relatives are at higher risk. It has been seen genetically. Okay, and you can say like mostly DM, like diabetic mellitus and hypertension. These two factors are the key here. You can actually say it's so familial propensity. Okay, familial propensity. So that's how we say it's pure risk factor which is connected to our heredity because of DM and STN. Okay, race. If we talk about race, alterations in lifestyle, diet and environment probably explain the geographical variations more than the racial tendencies, more than the racial tendencies. So it's change in the lifestyle basically. Okay, yeah. Now you come to hyperlipidemia. Okay, basically familial hyperlipidemia, we say that factor, but I would say it is a factor, but this risk factor is less compared to coronary heart diseases. Okay, it is there but not very big factor over here. Okay, let us talk about the next but very important factor, like again smoking, diet, obesity, all this again is less compared to coronary heart disease. Okay, hematocrit value. What is hematocrit value? Yes, wonderful. So high hemoglobin concentration, that means what? Yes, that's the hematocrit level. So high, if you see high hemoglobin concentration level is associated with increased incidence of cerebral infarction. Okay, I would say incidence of cerebral infarction. Cool. So you all understand now. Okay, one is remaining still. Okay, fine. Oral contraceptives, it's not clear, it's not a clear role of oral contraceptive. It is inconclusive till now, but some of the studies show that increased risk of, you know, but some studies says that increased risk of basically, if I say the subarachnoid hemorrhage, what we are going to talk much later, okay, it is associated rather than normal cerebrovascular diseases. Okay, I would say a sorry, I took the umbrella term name, but it's a thromboembolic stroke. If you say more than that, it has seen that subarachnoid hemorrhage has been associated. Is it clear, student? Any problem? You have any question? Yes. Yes. Good. Very nice. So you would remember, or you can say that if I see like like a risk factor, just 1 minute, I'll make it bold so that you can understand. Yeah. So now you'll be understanding all these thing easily. Okay. So as I said, stroke is a generic term, okay, lack pathological meaning. So this umbrella term we are going to discuss in detail. So these all are the risk factor basically, okay, these are the risk factor. So risk factor right from the hypertension, cardiac diseases, diabetes, heredity, race, hyperlipidemia, smoking, hematocrit value, oral contraceptives. So what we understood basically, hypertension, diabetes, and obviously because of that heredity, and then change in lifestyle are the major contributor for that stroke. Okay. Yes. Yes, of course, stress comes under lifestyle only. Good. Okay, so let us go to the next part after risk factor. Well, so we'll be talking about no, we are going to talk about first the natural history. Okay, but before the natural history, mechanism is something is very important. Just try to understand the simple mechanism. Okay. Okay. I don't know why this date is not changing. I'm not sure about it. Cool. So cerebrovascular just 1 minute. Yeah. Cerebrovascular diseases mechanism, as I said you, stroke is a kind of generic term, so that lacks the pathological meaning. So I'll just draw a simple picture to make you understand. Okay, and it's just a schematic diagram we are going to see. Okay, so it can be defined, what cerebrovascular diseases, it can be defined as those in which brain diseases occurs secondary to the pathological disorder of blood vessels. Anyway, by that time, let us just draw a simple image. We are going to discuss in much detail later, but just to make you understand the reason, it will be easy. I want you to study in such a manner that it works for you whole life. Okay. Yes, once you understand the mechanism properly here, you can understand the higher concepts later. I'll explain to you, don't worry. So this is my main focus for you guys. Okay. What I was saying you, the so cerebrovascular diseases are what? It is actually the diseases. It's a kind of brain diseases occurring secondary to okay, just 1 minute. Occurring secondary to a pathological, very important now, just try to understand. Pathological, this is the key. Once you understand, it will be working for your whole life. So it is basically secondary to a pathological disorder pathological disorder of okay, anyway, pathological disorder of blood vessels. Okay, remember students, blood vessels, usually arteries. Okay, but we cannot discount the veins or any kind of blood supply. Okay, so brain diseases are basically this. Okay, remember this. So now when we talk about this is very easy to understand the basic point, and I want you to understand the basic point. Okay, so what is this? I think just 1 minute. I'll take the pointed pen. Yeah. So what is this? This is a thrombus inside the blood vessels. Okay. So occlusion by thrombus or embolus. Clear? What is this? This looks like a kind of break from the continuity. Okay, this is the blood vessels, then it looks like a break from the continuity. What are we going to see this? What are we going to say this? It's a kind of breakage. So we will say rupture of the vessel wall, basically arteries, but we cannot discount other kind of blood supply as well. What is this? This looks abnormal than in the blood vessels. You all remember the levels, right? I mean the kind of layers of the blood vessels. You all remember? Okay. So this looks abnormal. So let us say this as at this point of time kind of diseases of vessel wall. Okay. Okay. Suppose the blood particles are moving here. Some changes are there in this. So what are we going to say this? This is disturbance of blood properties. So normal properties of blood. If you summarize all the risk factor, everything, you find this only. So you see, people say that I teach slowly. Yes, I do teach slowly because many of the person, they say later that I am faster. So I have decided to go slow. Okay, when you are revising the video, you can of course increase the speed of the video. Okay, what I wanted to say you that if in this case, suppose there is a this is a schematic diagram of a blood vessel, okay, and this is the blood vessel wall basically. Okay, you all know about the levels. We are going to discuss in much detail later. Okay, and this is the blood vessels wall. What all things could happen? Either occlusion by thrombus or embolus, or the kind of rupture, or the diseases, or disturbance of normal properties of blood. Anything it could be. So these all are the mechanisms. So these all are mechanisms which result into what? Ischemia, right? Ischemia, infarction, or you can say hemorrhagic disruptions. Okay. Hemorrhagic disruptions, anything. Okay, so this is the normal mechanism. So what do you think? Any kind of mechanism it can cause this. Now if you talk about incidences, in case of like overall, if you see the picture, then picture is very different. Picture is like okay, picture is 50% is hemorrhagic, only 15%, sorry, 15, I'm really sorry, 15% is hemorrhagic, and rest 85% is hemorrhagic origin, and 85% is infarction. Okay, this is 85%. Okay, this is how the things are till now. Okay, so you understood the normal mechanism, right? Very nice, thank you. Now let us see the next part. We are going to talk about the causes. Okay. Yes. So causes, as I said you earlier, whatever be the mechanism, there will be some causes, right? So mechanism I had made you understood. Now we will be discussing causes, and with the causes, what kind of mechanism has caused it. Okay. Yes, basically that, because you understood all kind of things are happening because of it is getting secondary to the blood vessel problem. Okay. Okay, first we are going to see the occlusion. Okay, just 1 minute, I'll make it. Occlusion, occlusion is 50%. Okay, occlusion is 50%. So you can say atheromatous or thrombotic occlusion. Okay, it could be large vessel occlusion or stenosis. That is any example of this. Example, we are going to talk about example meanwhile. Okay, carotid artery, very nice. Looks like you have studied this. Nice. Okay, so either it's a large vessel occlusion or it and or anything you can branch occlusion, right? This also can happen either in the main artery or maybe in the branch occlusion. Anybody can give example. Example is, anybody can give anterior cerebral artery occlusion. Very nice. Okay, or it could be, I'll go one step further, perforation. I would say perforating vessel occlusion. Whatever I am teaching you, just try to print in your mind, because based on this we are going to discuss in very detail in coming days. So like urinary infarction. Okay, just see occlusion and this much it has come. Okay, so in occlusion it was atheromatous. Well, now we are going to see non-atheromatous. Non-atheromatous. So non-atheromatous means what? You remember the mechanism? It will go exactly as per the disease of the blood valve, or it could be the problem of the properties of the blood. Wonderful, properties of the blood. So what are we going to see here? Just tell me, what are we going to see here? But let us summarize it. So rheumatic disorders, rheumatic, you can say rheumatic arthritis. Yes, it's a multi-system disorder. Yes, you're right. Or SLE, anybody can tell me what it is? Systemic lupus, tell me. Erythematosus. Yes, wonderful. So these all are the possibility. Vasculitis, right? Can anybody tell me one example of that? One example, just one example. Remember this word from now onward, temporal arteritis. Okay, remember this. Okay, or maybe the miscellaneous region. Miscellaneous regions, it could be miscellaneous diseases. It could be like example, if you see, it is a sarcoidosis. It could be trauma. Okay, any kind of trauma there. And there is a disease called FMD. And no, not foot, mouth and disease. No, not that. It's a fibromuscular dysplasia. Okay, so these all are the diseases, some of the examples, which is the non-atheromatous but can cause occlusion, because this, so that's the reason we are going to consider this as a reason. Okay, cool. Now after occlusion, what was the next? Embolization. Wonderful. How much? Almost 25%. Sorry. Okay, remember this, very, very important. Embolization, 25%. So again we will be seeing embolization, it could be because of atheromatous plaque in intra or extracranial arteries. Okay, intra or extracranial arteries. It is possibility. Or from aortic arch as well. Okay, it's atheromatous plaque. It could be the kind of heart disorder. You know, heart disorders can actually give rise to this. Example, if you see some of the heart disorders, you can tell me which can cause it. Now you can tell me, I think, once you understand the mechanism. Arrhythmias, okay. Arrhythmias, anybody? Valve disorder, yes. So we'll be putting it valvular heart disorders. Very good. Yeah, continue telling that. Okay, ischemic heart disease, that's wonderful. Patent foramen oval, that's right. So you understood now, right? So these all cardiomyopathy, even cardiac myxoma, rarely, but it can cause. Basically, I would write atrial myxoma. That will be more appropriate. Atrial myxoma. So, you know, these are all the conditions where the heart disorders from the heart, it can cause the embolization. Even more than that, like prosthetic valves also, or some of the diseases like patent foramen oval, what we listed, you know, some time back. Then anything else? Miscellaneous reason which can cause? Yes, please tell. Pat emboli. Okay, try to understand air emboli. See, there is nothing wrong in interaction. You can always tell. Tumor emboli. If you are not correct, I'll correct you. If I am also not correct sometimes, try to correct me. There's nothing wrong. This is how you are going to learn from the interaction. Yes. Okay. So, embolization, 25%. Remaining, you can say here we will be taking into account, you know, just 1 minute. Okay, here we are going to take account of, you know, like different diseases of circulatory system, like diseases of blood, like which kind of diseases? Diseases like any kind of coagulopathies it can cause, right? Or we can take venous thrombosis, okay, or reduced cerebral perfusion. These all can be the reason, right? Now we'll be talking about the other remaining factor, which is hemorrhage. This could be 20%. Okay, hemorrhage. So you can say brain substance or subarachnoid space, okay, in parenchyma, brain parenchyma, like suppose it's about 15%, or subarachnoid space, also 5%. Obviously hypertension is the reason, aneurysm is the reason. I'm listing all the important reasons. Yes, tumor could be the reason. Let us write like a neoplasm. Okay, hemophilia, that could be there, one of the coagulation disorder, right? Then any kind of vasculitis, all this. Then of course trauma, then drug abuse. Okay, all this could be the region of, all this could be the region of all could be the causes of, in fact I would say. So occlusion, as you said, like as you understood, 50%, then embolization, then hemorrhage, and don't discount these disorders also, these are important. Okay, so these all are the causes actually which are going to form. Okay, when we talk about occlusion, atheromatous, it could be the large vessel. Okay, like suppose there is a large vessel like this. Okay, internal carotid artery. Okay, and there is a bifurcation here. Yeah, so a carotid artery basically. So here is the problem. Okay, here is the problem. So it's the large vessels, right? But if it comes into branches, that's the branch occlusion I'm talking about. When we talk about anatomy, you'll understand even more. There could be, we were talking about some blood supply also. So it can have, like this. It can have blood supply like this. So anywhere kind of occlusion inside the blood vessels as well. These are all small vessels. The blood supply is disturbed. There also we see occlusion because of branch occlusion or perforating vessel occlusion. Okay, when we talk about non-atheromatous, you saw a lot of systemic disorders, right? Then embolization, here also atheromatous plaque in intra or extracranial arteries. Suppose okay, suppose there is a heart, and then this is superior vena cava and inferior vena cava came inside, and then there is a, I'm just giving you a schematic thinking to you guys. So here the aorta comes, right? And then this is how the aorta, arch of aorta is there. You all know. One more branch from here, sorry. One more branch from here. So this is how the, okay. So here what happened? Suppose there is a atheromatous plaque in this. Okay, it's extracranial, right? Atheromatous plaque over here. It's extracranial. Well, and or it could be, just 1 minute, I'll make the color disturbance. Yeah. So it is, suppose there is a possibility of atheromatous here, or maybe the aortic arch itself. Okay, atheromatous plaque is there. Or there are some heart disorders where you can actually consider the heart as a whole region, where the heart disorders are giving, we discussed about arrhythmias, valvular heart disorder, everything. Or ischemic heart diseases, these all can give a problem, right? So this is how I wanted to say you. Then don't discount this, as I said you, disease of blood, coagulopathies, venous thrombosis, reduced cerebral perfusion. Then hemorrhage, obviously, trauma, hypertension, aneurysm, neoplasm, some of the coagulation disorders like your hemophilia also, vasculitis, drug abuse, Okay, so basically brain parenchyma 15% or subarachnoid space 5%. Okay, this you should keep in the mind. Okay, so these all were the causes where, like, these things will form, and these things will cause cerebrovascular diseases. So now we are heading for pathology. Well, we can first we will understand the pathology, then we will get into the pathophysiology. Okay, occlusive cerebrovascular diseases. Okay, let me. Okay, so now we are here to understand this. So I would draw a normal blood vessel, how it looks. Normal vessel wall. We are going to understand this. There is a internal wall. Okay, there is an internal wall. Then there is a medial wall as well. Yes, we have name for that, we are coming on that. And then we have a thick collagen fibers making outer one. Okay, if you cut cross section, if you see the cross section of the blood vessels, this is how you are going to see. Okay, just a schematic diagram. So internal part, what is it? Tunica intima, right? Intima. Middle part, tunica media, and outer one, tunica adventitia. Well, what is this? This is a single endothelial. I hope you understand this. Just a minute. Just 1 minute, please. So it's a single endothelial cell lining. Okay, and very smooth. Well, tunica media, it has what? It has, yes, fiber cells. Then smooth muscles. Yes, so we'll be writing fibroblast. Okay, and what is that? Smooth muscle with collagen support. What about adventitia? Mainly of thick collagen fibers. You remember sometimes back we were talking about mechanism. In that we saw all these things, right? Sorry, in that we were talking about the blood vessels, how it get ruptured and which can cause, like kind of mechanism. But here we are going to see the blood vessels structure. Then in this structure we saw what? Tunica intima, media, and adventitia. You all know about it. Now the theory comes. What is the difference of the blood vessels consisting these layers inside the body and the brain? Different part of the brain, different part of the body will have different kind of consistency. So what is in the brain? Anybody can say? Brain and spinal cord. That is the CNS part. Do you know this is different? Tunica adventitia is very thin. okay, very thin. So elastic lamina, very thinly present. So elastic lamina between adventitia and media is almost less apparent. Okay, so intima is an important barrier here to leakage of blood and constituents into the vessel wall. Intima becomes more important here. Okay, this is how it allows. So whenever there is a plaque formation, okay, now we will be talking about the plaque formation and we will be seeing this. As I said you, the adventitia will be less present, it's thin one, okay, and media, and of course intima is the most important here, so we are going to talk about it. So what happens here, this atheromatous plaque forms, okay. So in case of development of this plaque atheromatous, okay, endothelium get badly damaged, which is the cell lining of tunica intima, okay, and that is the primary part it happens. Okay, so primarily what is happening, let us understand step by step. So first of all, endothelium of tunica intima is damaged. Okay, this is the primary event. Secondary, what it will lead to, intimal cells, I'm sorry for my handwriting if it is not working, there is some screen issue also. Okay, what it will lead to, smooth muscles, laden with what, cholesterol, basically triglycerides I mean to say, then phospholipids, lipids of course, and then collagen, which is basically the elastic fibers. Okay, collagen and elastic fibers. So basically these all are the subintima subintimally building up. Okay, so now what can happen, what it can lead to. Now what can happen, just try to understand. Hemorrhage, will it be disturbing now? So hemorrhage, it may occur within the plaque, may occur within the plaque, or just once, or the plaque itself may ulcerate. Just 1 minute. Plaque may ulcerate into lumen of the vessels. Okay, what it will form? Obviously, thrombus. So that is what is thrombus, right? So thrombus has formed. So it will obviously block the vessel. This is how it caused the block, occlude, right? Occlude the vessel. So I was talking about this. Here there is a plaque formation. Okay, either plaque can, within the plaque there is a breakage, or the plaque may totally ulcerate outside. In either case, it is going to cause the thrombus. It can block, it will block, I mean to say it will occlude, or I'll use the word stenosed, narrow. It will make it narrow. You understood my point? Either it may occur within the plaque, or plaque itself may ulcerate into the lumen of the vessel. Did you understand the point? Well, now, after knowing this, now the plaque itself may give rise to emboli. It can, right? So you understood now? Yes. Okay. However, in this emboli, I would say that important roles played by cholesterol, lipids, okay, phospholipids, basically cholesterol, esters, lipids, phospholipids, okay, all these are playing very, very important role that we are going to see later. But this is how the occlusion works. Okay, very simple. You understood the point? So what is the common common site? Common site or frequent site, whatever you say. Carotid bifurcation. Carotid bifurcation. Cool? Now, if we see a simple thing, just try to understand. Okay, I'll change the color first. Wait. Yeah. Situation you see. First situation I am giving you. The blood vessel is there. And okay, this is the first situation. If it is stenosed more than 80%, okay, so blood flow to brain will come down. Brain has automatic regulation. Every one of you know? Well, बहुत अच्छा. Very good. Yeah. We are going to understand. Okay. Or if you see it is occluded, now there is no more, like passing of blood. It is completely occluded. So what will happen? There is something, some symptoms will come, right? Clinical symptoms or outcomes, whatever will happen, but it depends upon what, how much it has happened, speed of occlusion, or it will depend upon the collateral circulation. Okay, very, very important. Collateral circulation. Okay, now let us understand the third situation where the blood vessel is anyway there, okay, and plaque which was formed here, this has moved, this has moved, it has ulcerated and moved. We were talking about, no, sometimes back, either it can give rise to the plaque or it may ulcerate into the lumen of vessels. So same thing, it has ulcerated. So this ulceration can cause cholesterol emboli or platelet emboli. Okay, this is the pathology, but we are going to understand even the pathophysiology. Okay, so very simple, you understood the, you know about the blood vessels cross section, right? What I said, inside the brain, this is not the same. Inside the brain or spinal cord, so basically CNS, okay, tunica adventitia is a thin present, it's a single layer present. Okay, so that's how the structure of this is different in brain compared to other part of the body. And if you see the plaque formation, atheromatous basically, okay, so what is happening here? It actually start causing the endothelium of the tunica intima, endothelium of tunica intima get damage. Okay, so damage to this, I forgot to mention here. Then what will happen? Damage to intimal cells. Then what will happen? The smooth muscles which is already present in the blood vessel, it will be getting laden with the cholesterol. It will be getting laden with the cholesterol. It will be phospholipids, collagen, all these things. It will get laden. So these all, till now, it was sub-intimally building up. Okay. After that, hemorrhage will happen. This hemorrhage will cause havoc. How? It can happen within the plaque, or plaque itself may ulcerate and get into the blood vessels. So the lumen of blood vessels will get occlude because of the thrombus. Okay, it can get stenosed, that means narrow, or it can completely get blocked or occluded. Cool. Now you come. Plaque may, that's the reason I'm saying you, plaque may give rise to emboli. Yes, but obviously there are important roles played by cholesterol, phospholipids. We are going to see in the next class. Yes, and common site is carotid bifurcation. Then we try to understood mechanism in pathology in 3 conditions. What is the condition? Condition number 1, if it is stenosed more than 80%, blood flow to the brain will reduce. Okay, brain has its own circulation, you know very well, right? Suppose the blood was, you have a blood moving here, and then it get stenosed here more than 80%, then blood flow to the brain will definitely reduce. Now, clinical symptoms will depend in case complete occlusion. Okay, occlusion, complete occlusion, full occlusion. What will happen? Clinical symptoms or outcomes, whatever you say, this will depend. This will come, but this will depend upon what? Speed of occlusion or collateral circulation. If collateral circulation is too good, it may not have bad outcomes. It may not have such, kind of worse outcomes. I would clear like that. Okay. Or if there is a atheromatous plaque, which I said can get ulcerate. Okay. This ulceration can cause havoc. How it will cause havoc? Because of, and in this havoc, cholesterol emboli, platelet emboli. Okay, this ulceration can actually give rise to cholesterol emboli, platelet emboli, and this can cause havoc. Understood my point? So these three situations you can understand. Now, pathophysiology involving different chemicals we are going to see in next class, no doubt. But pathophysiology, okay, pathophysiology in terms of what is happening in that particular area can be understood easily. Okay, you are ready. If you are ready, then I am ready. No problem. Yes, no problem. So let us see here. Pathophysiology. Okay. So we are going to understand this pathophysiology in two ways. First, we are going to understand, in a standard way, like how it works on the brain. Okay, like what is happening to the hemisphere of the brain, and what is the actual on the brain parenchyma, how it works. And then pathophysiology of ischemia we are going to understand in a way where the chemicals work. Okay, we are going to see the cascade, ischemic cascade. We are going to see the role of neurotransmitters. Okay, so it's going to it will take some more time. So if you are ready, I am ready for that. Okay, well, understood. Thank you so much. So let us talk about it. Now, I'm going to draw a schematic diagram so to make you understand. So first of all, let me tell you standard techniques of cerebral blood flow measurement. Okay, it actually provides information in both, in like a terminal blood flow, I mean to say global blood flow, and regional blood flow with the patients with ischemia or infarction, cerebral ischemia and infarction. Okay, so a lot of technique like PET and all has helped a lot, and then obviously glucose metabolism, everything has helped a lot to understand the course of pathophysiological changes which happens after the stroke, to make it more clear. Okay, so well, now we are going to see the changes in cerebral infarction. Okay, changes in cerebral infarction. Okay, I'll do one thing. I'll make you understand with ischemic and non-ischemic way. Okay, just 1 minute. I'll do it with the black schematic diagram. It'll be easy for you to understand. No, no, please don't misunderstand with the lung. This is for just a schematic diagram I have given you. Don't misunderstand with the lung. No, 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 not at all. In just 1 minute, let me draw, then we will explain you. Like we'll talk more about it. I'll explain you everything. Then you can let me know. No problem. You know how I studied? I try to make you understand that also. And those books, those notes, I remember. And later I studied from different part, different process. So this is how. So the basic part we should be very clear about it. Okay. So this is basically the hemisphere I have drawn. Okay, one hemisphere is showing like how it is happening, and just a minute, let me complete this drawing, then I'll tell you. Okay, now let us talk about it. Okay, see here, this is a non-ischemic hemisphere. What is that? Non, that means it's normal. Yes, hemisphere. Okay, non-ischemic hemisphere. We are going to see the changes in that, right? So what is happening in this non-ischemic hemisphere? I'm talking about this basically. So mild reduction in cerebral blood flow. Should I use the short form? No problem. Global cerebral blood flow. Okay. Yeah, there is a good question. I was reading the question only. Yes, why there is a mild reduction here as well? Of course, that will happen because of you can say both the side, right? So transneuronal depression of metabolism. Yes, transneuronal depression of metabolism in normal hemisphere. Clear? This is the reason. Understood? Any other question you have? Okay, whatever question, just list it. We'll talk later. Okay. So in normal brain, what is happening? Cerebral blood flow to the part will vary. Okay, it will vary to any part, to any specific part, you can say. Part will vary. Why? because it depending upon the metabolic requirements. Okay, so what is the requirement here? If we talk about it, metabolic requirements, what I mean by the metabolic requirements, it is basically the I mean to say that is your oxygen and glucose. Oxygen, glucose and water, these three things are utmost important for the brain. So oxygen and glucose requirement, metabolic requirements. So supply of oxygen and glucose to particular part is very, very important and is coupled to the tissue needs. Okay, so after infarction, till now we are seeing only in the normal lobe, I mean the unaffected lobe. So after infarction, what is happening? Between areas of reduced blood flow, just a minute. Okay, after infarction, what is happening? Let me tell you after some time when I talk about this, affected ischemic one. Just 1 minute, I'll start for this as well. So ischemic hemisphere. Ischemic hemisphere. What is happening in ischemic hemisphere? The most important is reduction in global cerebral blood flow. Clear? So we had discussed a very detail about this cerebral blood flow and pressure, everything, right? You remember that picture? No problem. You go to home and then discuss about it among yourself. You study about it, and that is one of the key picture, that gives you a lot of details. Well, that is even uploaded on the YouTube, so you can actually talk to your class coordinator and then find out. No problem. So what is happening in the infarcted area brain? In the infarction area, infarcted area and nearby surrounding it, you can expect more subtle changes. Very, very important words. Changes of cerebral blood flow. Okay. Actually, if you see this image, basically this image, I'm talking about this image here. Okay, let me tell you first. Areas of reduced blood flow, so areas of reduced blood flow are bordered by increased blood flow. What we say, the areas of increased blood flow, that is called what? Anybody? Luxury perfusion. Okay, what is called luxury perfusion? Why it is happening? Very simple, due to vasodilation of capillary bed. So here we will be writing arteriolar bed. It is better to write like this: arterial bed. Capillary bed get vasodilate in response to lactic acidosis. Now don't compare this lactic acidosis with something what we have studied earlier. Okay, lactic acidosis, basically that. Okay. Well, this was very like a wonderful thing. Now if we see here in normal, so after infarction, what is happening here? After infarction, between areas of reduced and reduced blood flow and increased blood flow, I would say that increased blood flow, let us write like and luxury perfusion. This word has to be repeated again. And the luxury perfusion, I'm not sure if I'm not writing the word correctly. Luxury perfusion. Luxury perfusion. Yeah, sorry for spelling mistake. So after the infarction, I'm talking about the normal hemisphere. What is happening after the infarction between the areas of reduced blood flow and luxury perfusion? There is a area, okay, lie areas of relative luxury perfusion. This you remember, please. Areas of relative luxury perfusion. Where a reduced flow exceeds the tissue requirements, right? Tissue requirements. I hope you are understanding all this. Okay. So basically that is the uncoupling of metabolism and blood flow. That is what is happening here. Now, this is what I wanted to say you for non-hemispheric hemisphere. What is happening? Mild reduction due to transneuronal depression of metabolism. Okay, and cerebral blood flow to any specific part will vary depending upon what? Metabolic requirements. That is what is supply of oxygen and glucose anytime. So after the infarction, basically between the areas of reduced blood flow and luxury perfusion, which we have seen that side, lies the areas of relative luxury perfusion, where the reduced blood flow exceeds the tissue requirements. Okay, so that is what is uncoupling is happening. Clear? Anybody has any question on this? Please ask me. Now come to this part. When it is a ischemic hemorrhage, story is different. Why? Obviously, there is a reduction in global CBF, which is very, very important. Okay, and areas of reduced blood flow. Reduction of global CBF. Global. I mean to say like pan brain. Okay, full brain, and the infarcted area and nearby more subtle changes of CBF is seen. But when we talk about, okay, there is light problem. When we talk about this, a small area here where the infarction has happened, okay, when we see into detail, what is happening here? Areas of reduced blood flow are bordered by area of increased blood flow. That is what is called luxury perfusion. Due to what? Due to this particular thing. I have written the plus, right? This is the reason I have written plus. Why? Because this is a vasodilation. This brings more blood in arteriolar bed or capillaries in response to lactic acidosis. Well, just give me 1 second. Just 1 second. Yeah. Is there any problem with the light now? I hope it's cleared. Yeah. Cool. Okay. Now, now this was the story when, we see what all the changes are there in the cerebral infarction and how it is going to function when it is happening, like ischemic cascade is happening. That time how it is happening. But now if I say basically what is happening immediately after that? Reduced regional, in the infarcted area and nearby more subtle changes of cerebral blood flow was seen. So I mean to say, let us name it like a regional. Okay, a regional. So it is like RCBF. It will make more sense now. So these changes are transient. Okay, these changes are transient and revert to normal. Revert to normal within days of onset. Okay, but the degree which the regional cerebral blood flow, what we were talking about, the changes in regional cerebral blood flow are quite transient and revert to normal within days of onset. But the degree of disturbance of regional cerebral blood flow, it actually correlates with the outcome. Okay, will you remember that? Degree of disturbance correlates with outcome, clinical outcome, whatever you see. Okay, so there is a data. I'm just writing. Suppose the flow of 28 ml per minute per 100 gram is not happening. Okay, flow of 28 ml per minute per 100 gram is not happening. It's getting less than that. Will result into development of morphological changes in infarction. I said you this is very very important when it comes to the how much it is happening. So I'm just making the color changes also. Wait, so that you can remember these things later. Please remember this, very important. Okay, degrees of disturbance always depends upon how much it has caused the damage. Okay. So after learning this, yeah, so there is a difference, right? There is a good question here. The question is asked like, do we have to write in examination the pathophysiology for cerebral infarction only and only in this manner? No, I don't say that you have to write in this manner, but if you write this, this gives a very clear picture, not just of the ischemic hemisphere, what is happening, it gives the idea of what is happening in the non-ischemic hemisphere as well, which you are supposed to write. Cool. So make sure that you are writing in such a manner which is more descriptive and with the image. Always use the images in your answer book. You know, image gives more satisfaction to anybody who check your answer book. Okay, so you understood till now here. Then we will be seeing the pathophysiology of ischemia. Okay, so how much the disturbance and what is the, you know, like some graph we will see. So let us go to the next page. Just one sec. I'm going very slow so that every one of you can understand that. There is no problem. If you feel that I'm very slow, I can be more faster. Let me know about it. So there are two graphs I'll make you understand. Before we get into the ischemic cascade pathophysiology, we are going to see properly through the graph. Very simple, two graphs. Just one sec. Okay. Okay, this is for the threshold of cerebral ischemia. I am making you understand. I'll write it down, don't worry. This is to make you understand. Okay, so that you can understand that. Now, okay, just 1 minute. I'll change the color for your better understanding. Okay, what I want to make you understand, this part of the graph which shows the cerebral blood flow, okay, and it is in the ml per minute per 100 gram. Okay, this is how it is. So if it is this level, up to, let us say 20, okay, let me draw first, then I'll explain you. Okay, as I said you, in this y-axis, cerebral blood flow has been indicated, constant cerebral blood flow, okay, with 0, 10, 20, 30, 40, 50, 60. You remember from our last, just now we studied 28 ml per minute, right? If anything get reduced than that, 28 ml per minute per 100 gram, that will develop the morphological changes of infarction. Now, let us see if it is at 20, what is happening at 20? If it is at 20, electrocortical functions affected. What is happening when it is at 15? Around 15, it is electrical failure in that particular part, okay. When it is at 10, what is happening? It is ionic pump failure. Those who have not attended my class on the ionic pump, please go and attend. And when it comes to the below 10 and then almost near 5 or 0, it will cause death. So those who have not attended, I said, can actually go and attend. Just 1 minute, I think the colors are different. That will give you very fair idea how the all or none law works, and lot of things we have discussed there. Okay, so this is how it works. Okay, this graph is give you a simple presentation. Okay, now let us talk about a different graph. This graph is equally important, but this time I am going to draw not for constant cerebral blood flow. This time, just 1 minute, sorry. This time I am going to draw for regional cerebral blood flow. Okay. So, y-axis, regional cerebral it's difficult to write like this, blood flow. This time I'm not talking about constant blood flow, okay? It's a regional, wherever the infarction has happened. Again, the measurement will be same, ml per 100 gram per minute. Yeah. And then, of course, duration in x-axis, duration of ischemia, and how ischemia can bring the cascading effect. So if you see that graph is very simple, it says like this, okay, and this is the part where the infarction happen, and I would say that reversible reversible deficit. So whatever is damage in this part, this can be reversed. Okay, but this infarction part cannot be reversed. Now, what is the important thing you can understand this through this graph? Yes, exactly. So more the duration, less is the chance of ischemia reversal. Just 1 minute. Just 1 minute. Sorry for my handwriting. Something is problem with the tablet. Next time I'll try to do with better handwriting. No, it is important too. So basically what I was saying you, it is the duration of ischemia. Okay, more the duration, less the chances. Less the duration, there is always chance of reversible deficit. You understood? So these two graphs, I would say graph number 1 and graph number 2, this is to make you understand, keep in the mind, and always try to recollect whenever you revise. Try to recollect through this graph. Okay, so now we will be talking about ischemic cascade. Okay, so how the significant fall in cerebral blood flow produces a cascade of events, which can lead to production of lot many harmful chemicals, and it can eventually go to the apoptosis, programmed cell death. Yes, I have classes on physiology as well. I'm not sure that has been uploaded. They'll start from the sport physiology. Yes. They'll upload everything. Don't worry. One after another. Okay, so ischemic cascade we are going to talk about. So, as I was telling you, significant fall in cerebral blood flow produces a series of events which, if unchecked, can lead to production and accumulation of harmful substances, of, I would say, toxic chemicals and eventually apoptosis. You know apoptosis? Programmed cell death. Yes, correct. Actually, you don't need any notes. If you see these videos, this video itself is a note. If you want to take down, I think there are some AI softwares are there where you can take down the notes from the video. I have never used it. Sorry, I have not used it, but I learned it. Okay, so now let me see if I can do it just with this one. Otherwise, I'll use the again tablet Only thing that tablet is not working so good on the tablet right now. I'm in the screen, so but still let me try. Okay, so what is the happening? Mismatch between cerebral blood flow and metabolic demands. Metabolic demands, that means oxygen and glucose. Clear? Just a minute. So it can lead to electrical failure. Just now we saw that, okay, after certain this one, it can lead to electrical failure, and then eventually it can lead to what? Ionic. If it continues, you know, regional cerebral blood flow is reduced, then it will go for ionic pump failure. Clear? Then it will lead to what? Sodium ion, Na plus, what you write? Na plus influx. I think you must refer that class. Influx means it will get inside the neuronal cell. And what it will lead to? If Na is getting changed, then K plus ion also will be changed. Efflux, it will go out, so it will be from neuronal cell. Rather neurons, just use the word neurons. Okay, fine. So what it will eventually lead to? It will go for calcium ion influx, which will just 1 minute, which will basically what? Activates which will actually activates membrane phospholipids. Membrane phospholipids. This will it will activates basically membrane phospholipids gives that, so I'll leave that. It activates the basically the enzyme phospholipase A2. Okay, and if you ask me where it comes from, it actually comes from normal membrane phospholipids. Okay, membrane phospholipids is something which actually gives this this enzyme. Now, phospholipase A2. Arachidonic acid. Okay, now here the actual story starts of damaging. this gives this gives two different enzymes. I'll discuss one by one. One is what? One is cyclooxygenase. I could have, made this table and later I would have made you understood, but I thought I'll do along with your understanding. Okay, so that you can remember later properly. And another, apart from cyclooxygenase, another is lipooxygenase. This is a cascading effect. It goes, and these many enzymes will actually give rise to number of chemicals. So starting with, I would say, I'll write it in cap, prostaglandins, prostaglandin, and then another is, basically these are free radicals. Okay, and basically hydroperoxides, see how cascading effect is. Hydroperoxides. Free radicals are something which will actually cause the damage. Free radicals and then hydroperoxides. I would write here neuron damage. Okay. So let us put it in red so that you can understand well. Okay, neuron damage. Now, these free radicals has caused it, right? Apart from that, if you see other activities, I mean to say from this side, thromboxane A2, just 1 minute. thromboxane A2 endo prostacyclins. These two are released by or you can say it is a change endoperoxides which actually gives rise to you know thromboxane and prostacyclin. What will thromboxane do? I would say thromboxane A2 is a potent vasoconstrictor, and platelet aggregator. Aggregant. Okay, but what prostacyclin does? It's a potent vasodilator. Potent vasodilator and platelet anti-aggregant. You can see how contrasting the properties are. Well, now just a minute. Now these two, if you see these two, actually speaking, these two are a major contributor in again of course diagram took more time today, sorry, but try to make you understand as I am teaching. That's the reason I did not draw. Okay, this is the major reason. You can see neuronal damage. This is caused, actually this is so this is causing neuronal damage. Okay, endoperoxides itself, everything here you saw how it is causing. Now let us see one more scenario. It was when electrical failure happened, but what about if there is lack of glucose and oxygen? What happens in cell? Anybody? Yes. Anything else? No. What happens when there is a lack of metabolic stuffs in the cell? Anaerobic metabolism or respiration. What it gives rise to? Lactic acid. Wonderful. So then it is very important to understand the cell physiology. Okay, So lactic acid it gives. So lactic acidosis, environment is caused, right? And lactic acidosis will cause in turn neuronal damage. So to understand that, or to make it, in a quick review, which I took little more time, I'm really sorry. You can see there is a mismatch between CBF and metabolic demands, that is oxygen and glucose inside the cell. So either it can go for electrical failure, or it can go for electrical failure, then ionic pump failure, then sodium plus ion, it is sodium plus ion, what do you say, influx into the neurons, then potassium ion going out of neurons, then calcium ion influx will happen, that will activate membrane phospholipids, and that is where the phospholipase A2 enzymes will come into the picture. Okay, and this is where the enzymes are very dangerous. If you see in this case, phospholipase A2 has come, okay, and then it causes arachidonic acid or even other free acids into two enzymes. You can see here cyclooxygenase and lipoxygenase. Cyclooxygenase in turn give prostaglandin and obviously free radicals that will lead to the neuronal damage. Okay, now if you see hydroperoxides, also obviously peroxides are there that will go for damage. Okay, well, apart from that, if you see here endoperoxides, thromboxane A2 and prostacyclin. What is that? Thromboxane A2, vasoconstrictor and platelet aggregant. But in contrast, prostacyclin is a potent vasodilator and anti-aggregant of platelets. This will also cause what? Neuronal damage. Okay. Now, if you see another scenario, another scenario is, as we talk about, there is a mismatch of oxygen and glucose. So what will happen? Anaerobic metabolism. Oh, sorry, the spelling was wrong. Okay, this will cause lactic acidosis. Okay, and lactic acidosis will in turn cause the cell damage, that is neuronal damage. So how good it is? You understood the table? You understood the flow chart? Yes. Yes, I could have made it. I feel that I could have made it so that it would have been easy to understand. But again, interaction with you guys and then teaching one by one is always a joyful thing for me. Now, if you talk about the role of neurotransmitters, then I would say, you want to understand, then I'll make you understand. Otherwise, we can stop here. Otherwise, if you want to understand, I'll make you understand. Okay, basically, no problem. I'll see into this. So basically, if you talk about role of neurotransmitters, yes, there is obviously a very role of neurotransmitters in case of ischemia has been seen, and this is very, very important to understand, at least if you remember the name of those neurotransmitters which has been found in studies. Very important for ischemia, responsible for ischemia. So it has shown that glutamate in excess is a powerful toxin substance. Yeah, toxin. Okay, you remember that. Now, if you want to understand how it happens, a simple flow chart can make you understand. Well, now you see there are two things. Just 1 minute, I'll change the color for you. There are two things here. One is glutamate, okay, and another is glutamine. So in our flow chart, we'll use both in a different way. Not glutamate, just 1 minute. Glutamine. I wanted to write the amino acid, but I wrote the enzyme. Anyway, see here. Glutamine, sorry, I'm really sorry. Glutamine. So glutamine, we will see GLU. Sorry, I'm really sorry. Both I'm getting confused. Just 1 minute, bear with me. One is glutamine and another is glutamate. Okay, so glutamate we will see GLU and glutamine we will see GLN. Okay, now if you understand the neurotransmitter, how it works, okay, so at presynaptic terminal, you remember, no, that in my class I made you understand how it happened, presynaptic and all, ion influx. Remember this picture, right? Okay, fine. So I will not get into detail of that. Those who wants to understand can go to my previous class and can understand from there. So at presynaptic terminal, what is happening? Just 1 minute. I'll just make a simple diagram to make you understand. It will be easy for you. So this is a this is presynaptic terminal, okay, and this is astrocyte, one of the neural cell. Okay, you know very well, glutamine will come from where? Glutamine, okay. It will give rise to glutamate. How? When one ammonia goes away from this. Clear? Okay. Now here, suppose this is schematic diagram of postsynaptic dendrite. Okay. Postsynaptic dendrite. Okay. Here what is happening? Here there is a glutamate receptors. You know, all the story is of the receptors when it comes to the synaptic channel transmission, neurotransmission. Okay, glutamate receptors. Right, huh? Glutamate receptors. Here, it is received by glutamate receptors, right? Okay, toward this. So what is happening here basically? This particular glutamate is getting again it is uptaken by this, so we will see this reuptake, okay, and the same glutamate is where is getting into astrocyte, okay, lot of glutamate, you can see that, right? And this glutamate again get converted into glutamine. How? When one ATP convert into the one ADP, adenosine triphosphate get convert into the adenosine diphosphate by the process, okay. Here also we will see what? Reuptake. Just a minute. So this is also is what? Reuptake. Here also it was reuptake. Here also it is a reuptake. Okay. Now, if you see the ischemia's condition, what is happening in ischemia? Increased glutamate, okay, increased glutamate either through releasing or less in uptake, okay. What is happening? There is a deposition, there is a glutamate in excess, okay, glutamate in excess. What will it cause? It will cause breakdown of arachidonic acid, and you know the story what happened above. When arachidonic acid got broken, then cyclose oxygenase and lipoxygenase, everything was, these two were released. You can see here, you saw here arachidonic acid, these two, and then after that free radicals, prostaglandins and hydroperoxides, which led to the neuronal damage. But in between, what will happen? Here depolarization will happen. Depolarization will happen for sure. So depolarization means what? Sodium ion in, potassium ion out. Well, calcium channel open, okay, and calcium ion in, calcium channel in. So this is what is happening and causing the tell me, it will cause the phospholipid to come into the picture. So after the depolarization, as you saw, This will cause what? Activation, activates phospholipids, and you can see in our picture what happened, and then obviously it will go for the breakdown of arachidonic acid, and you can see above picture, above flow chart, I would say, how it went for neural damage. Okay. To understand. Understood? So glutamate excess is one of the reason where it happens. So where actually it works, if glutamate excess is there, we can include here. Okay, let us glutamate excess glutamate can cause now you understood the process, right? Yes. So excess glutamate basically activates the membrane phospholipids and then phospholipase A2, and that's how the breakdown of arachidonic acid happens. Then you know the thing like cyclooxygenase, lipoxygenase, prostaglandin, free radicals, hydroperoxides, and ultimately leading to the neuronal damage. So you understood the role of neurotransmitters as well in the pathophysiology. So today what all things we understood, I hope everything has gone well with you. So right from the introduction part, if we see, we saw introduction, we saw risk factors, then we saw the normal mechanism, then we saw the causes, okay, occlusion, embolization, hemorrhage, you know, from where it happens. Then we saw the occlusive, like how normal vessel wall looks, and then how plaque get formed, how emboli, you know, get proceed ahead with important roles played by the cholesterol, lipids, phospholipids, everything. Then we saw the three situation: stenosis, complete block, and even the ulceration of plaque. Later we saw the pathophysiology of cerebrovascular disease in very detail. We learned about the thing by contrasting the difference between the non-ischemic and ischemic hemisphere of the brain. Then we understood what is luxury perfusion. We understood when the things can go wrong after, you know, like a reduction of cerebral blood flow to a very low value. It can cause even death. We understood through the graph. Duration is the key, you understood. In case of you want to reverse, you want C to reverse. And then we saw the ischemic cascade, which was a little longer. I'm really sorry that I took your time, but it was very good that we understood one by one everything. And we understood even the role of neurotransmitters, and especially glutamate. You should always remember glutamate is excess is a powerful neurotoxin. How it works? It works basically excess glutamate. It actually works at membrane phospholipid level and then giving to phospholipase A2, and then later you know how it gives the free radicals, prostaglandin and hydroperoxides, leading to neuronal damage. So till today, today we finished all these things. I hope it has gone well with you. Thank you so much. Thanks a lot.